I'd like to very briefly review some of the history of transplantation and go over the most commonly accepted indications, talk very briefly from a very non-surgical perspective about the procedures themselves, address some of the disease-specific considerations as we consider patients with different diagnoses for transplant. And we'll talk about donor characteristics, outcomes, and complications. But then what I'd like to talk about are 5 or 6 different issues that I think are in the forefront of how we're considering transplantation these days, and talk about some of the at least interim solutions that are on the horizon for those different problems. These are some of those topics that I'd like to come back to and probably spend the last half or 2/3 of the talk on. Should we be looking to expand the indications for transplantation, not only in terms of the ages of people that we transplant, the ages of people from whom we accept donor lungs, but also what can be done to make candidates for transplantation more suitable for the procedure. Can we take people who are afflicted with such end-stage respiratory disease that they can't rehab, they can't do a 6-minute walk of 200 meters and so forth, and can we use newer technologies and newer thinking to try to get those people to transplant? We'll talk about ways to expand the donor pool, some of the current thinking about bronchiolitis obliterans and chronic lung allograft dysfunction, and then sort of the holy grail of all transplantation is how to get the host to really accept the allograft without all the rejection problems and the need for anti-rejection medications. The history of lung transplantation doesn't go back all that far. The theoretical work that underlies it was really a product of the 40s when some of the surgical techniques were being developed, and at that time it was recognized that airway ischemia is really one of the major and continuing problems. The bronchial circulation that supplies blood to the bronchial structures and mucosa, certainly in the more proximal parts of the donor airway, is not reestablished in the vast majority of lung transplant cases. There are ways to do that, but they're technically difficult, and most programs rely on sort of back perfusion from the pulmonary circulation to keep those airway segments perfused, and that remains a bit of a weak link that surgical techniques have had to be developed to come to grips with. The first human lung transplant was done in Jackson, Mississippi, in a 58-year-old man who had lung cancer. The donor organ was taken from a recently deceased individual, not a brain-dead donor, sort of presaging the current enthusiasm for the possibility of using donors who die of cardiac death, not of brain death, as potential organ donors for not only lungs but a variety of different systems. Things really became more practicable when calcineurin inhibitor medications became available for immunosuppression, specifically cyclosporin, and then followed by the work in the late 70s and early 80s that Tom Startzel and colleagues did at Pittsburgh with what we then called FK506 and now know it as tacrolimus. The first heart-lung transplant for advanced pulmonary vascular disease was done by Bruce Rice at Stanford in 1981, and for a long time, heart-lung en-bloc transplantation was the preferred procedure. Those of you who were at UAB remember the young man that I cared for a long time, gentleman who never was seen without a chaw of tobacco in his cheek and had strong roots up in Walker County. He had a heart-lung transplant at Stanford in about 1990. His heart, which was fine, his lung problem was cystic fibrosis, and his heart had no problems, was dominoed, in the current parlance of the time, to a young woman who needed only a heart. And this man and his heart recipient partner were featured on Oprah and all sorts of other places as special friends because of this relationship that was deemed to be on a par of people writing to convicts and marrying prisoners and things like that. Those were the other sorts of folks that Oprah had on the show at the time. The practicability of dedicated lung transplant alone is traced principally back to Joel Cooper. Dr. Cooper was at that time in Toronto and has been a couple of other places since then, but he showed that you could achieve multi-year survival in lung transplantation, principally early on for pulmonary fibrosis and in the setting of a single lung operation. It was felt that you couldn't put a single lung in somebody with emphysema because the native emphysematous lung would overinflate and crowd out the new lung, and it was some time before that it was shown again by Cooper and colleagues that you really could do that successfully. And for a long time, single lung transplantation for many diagnoses was the preferred procedure. The first group of those transplants, essentially all single lungs, was reported in the mid-'80s. For a while, there was enthusiasm for en bloc double lung transplantation for bilateral disease. It was recognized that you really couldn't put two clean, pristine lungs in, or put, a single pristine lung in somebody who was chronically infected on the other side, for example, with cystic fibrosis or non-CF bronchiectasis. So for those kinds of diseases that required two new lungs, it was commonly done to take the lungs out en bloc and transplant them into the recipient with a single tracheal anastomosis and then the various vascular anastomoses. It was shown pretty quickly in that experience that the major issue with ischemia at the tracheal anastomosis had not been solved, apropos some of the observations of 40 or 50 years earlier, and that operation fell out of favor. It was replaced around 1990 by a sequential bilateral lung transplant, which now remains the principal procedure for bilateral transplantation. And most people now do it through sequential lateral thoracotomies. So they'll roll the patient up, do a lateral thoracotomy on one side, extirpate the native lung, put in the transplanted lung on that side, make all the requisite hookups, and then close that side, roll the patient the other way, and do the same procedure on the other side. The lateral thoracotomy gives the surgical team much better access to the pleural space and to the hilar structures that need to be attended to. There was enthusiasm for a while, principally in cystic fibrosis, for these clamshell procedures where a lateral transverse incision was made across the lower part of the sternum and the chest was reflected cephalad to get there, but that made it real hard to get to the structures that the surgeons needed to have. There was for a while some enthusiasm for lobar transplantation principally in cystic fibrosis, where you could take single lobes from adult-sized donors and use them to replace entire lungs in a CF child. We cared for a number of those people at UAB. That operation has largely fallen out of favor. It was principally done because some of these children and adolescents with CF couldn't wait long enough under the old time-based priority system that was in place prior to 2005, and because there was no need for a waiting list, donors could be identified. They didn't have to be family members, though they often were. Dr. Starnes at Stanford tells stories about rock groups picking members of their band to donate for their drummer, church groups getting together to donate for a member, and so forth. But since 2005, when the lung allocation score system was introduced, a need-based allocation system that prioritizes people based upon the severity of illness and the likelihood of death prior to transplant compared to the likelihood of a good survival following transplantation, the need for hurry-up systems like lobar transplantation and living donor procedures has largely gone by the wayside. My surgical friends joke that this is one of the few procedures where you could theoretically have a 300% mortality per procedure. Thankfully, again, that's not something that people have to mess with. The first decades of the new century have been marked by a number of advances. There are centers that are already beginning to expand criteria for selecting recipients and donors from which organs can be taken. We had a brief but largely successful experience in Birmingham transplanting for one particular kind of malignant lung disease, what's now called adenocarcinoma with lipidic spread. Back then was called bronchioloalveolar cell carcinoma, a tumor that rarely, if ever, metastasizes outside the lungs and could be successfully treated only with transplantation. We had survivals in that group of people comparable to the other patients we were transplanting, but it again is something that most centers have shied away from now. This decade is being marked by exciting developments such as ex vivo lung perfusion, we'll talk about in a short while, the potential use of donation after cardiac death. These are people in whom care is going to be withdrawn because they have some terminal illness that withdrawal of care takes place in the operating room, and death is established when the heart stops beating, not using brain death criteria as we so commonly do in the ICU. And there is an evolving experience with organs retrieved after that sort of procedure. And then very exciting things that we can do to make transplantation available to people who 10 years ago would have been said to be too sick, using extracorporeal systems and so forth. So we've come a long way already, but I think those people who are in the field recognize that we still have a tremendously long way to go. The number of transplants has increased dramatically. Again, we sort of trace transplantation in a practical way back to the mid-'80s. We did our first one at UAB in 1989 and only did a couple a year for several years. We hit our stride in the early 90s when we peaked out at about 40 or 50 transplants a year. The most successful centers, the most active centers now are doing between 100 and 200 procedures a year. And there really is a volume effect. Centers that do that many really have a very good system in place. I don't have the latest figures here, but the current numbers are up over 3,000 procedures per year. And what you can see is that the number of single lung transplants in green has really plateaued as we've begun to recognize that double lung procedures are probably more appropriate for the vast majority of recipients, and allocation systems have made double lung or bilateral lungs available to centers on a more routine basis. So there are still occasional centers doing a significant number of single lung procedures, but the bilateral procedure, as I mentioned, has really become the standard against which things are measured. Outcomes are not what we would like them to be, in contrast to liver transplantation, for example, where if you survive your first year post-operatively, you have an essentially normal life expectancy. The liver is a remarkable organ. We haven't achieved that in lung transplantation. There are a number of really limiting complications, the principal one of which is various forms of chronic allograft dysfunction that we'll come to. But most centers achieve median survivals in the 6 to 7 year range. The 5-year survival numbers for most of the better centers are between 60 and 80% now. Again, respectable survivals for the mortal diseases that we're trying to help, but certainly not where we would like things to be. There is a little bit of a difference by diagnosis, although it's not as great as you'd think. This curve shows survivals over up to 15 years of people who get primary transplants for cystic fibrosis in green, COPD in red, and various forms of interstitial lung disease, principally idiopathic pulmonary fibrosis in blue. There is a little bit of a difference. The CF people do well, probably because of their age and the fact that they don't have some of the other comorbidities that older patients suffer from. What's striking, though, is that if these patients require retransplantation, all three disorders do less well. The underlying pathophysiology of that drop in survival for retransplantation isn't well understood, but probably has to do with the fact that most retransplants are done for chronic lung allograft dysfunction, or chronic rejection as it's commonly referred to, although the possibility that it's non-immunological is a very real one. And that seems to be a particularly severe problem in people who require retransplantation. There are a variety of summaries out there. This is one of the nice ones. Alice Gray and colleagues at Duke recently published their experience. This is all from 2005 forward, once the lung allocation score was put into place and changed the distribution of things. But you can see, just looking at the lower half of the slide here, that obstructive lung disease, principally COPD, CF, and interstitial lung disease, principally IPF, together constitute something like 80+% of the diagnoses for which people are transplanted. So while there are a smattering of transplants for other diagnoses, those are the big three. Those are the ones that most centers concentrate on. And the median age is creeping up. It used to be that 60, 65 was sort of the absolute cutoff for many centers. Most centers now use age as only a relative cutoff and look at physiologic age, if you will, as a much better indicator of how people will do following transplant. I've mentioned that the type of procedures being used are evolving. Single lung transplants can be successfully used in COPD. various diffuse parenchymal lung diseases like IPF and sarcoid, but even these people now principally get bilateral transplants, as has always been the case for septic lung disease, CF and non-CF bronchiectasis, and pulmonary hypertension. There have been descriptions of successful single lung transplant for pulmonary arterial hypertension, but there are inherent issues with all of a sudden shunting most of the cardiac output to the native lung in its, to the allograft lung in its fragile postoperative state. Interestingly, though, the development, the aggressive development of very effective therapeutics for various forms of pulmonary arterial hypertension has made this not a vanishing indication for transplantation, but one that's invoked much, much less commonly than it was. Congenital heart disease with pulmonary hypertension is still best managed with heart-lung transplantation, but that's an operation that's really almost disappearing because of the difficulty of getting heart-lung blocks. Most hearts these days go to very high priority people already on various forms of mechanical support, ventricular assist devices and so forth, and it's hard for people to successfully get a heart-lung block for other indications. This is a standard set of criteria that have been proposed for the selection of donors, not recipients now, shifting to the people from whom the lungs are generously donated. And I put it up here not because it's being used so much anymore, but just to show you where we've come. We rarely accepted donors over the age of 50 or 55, but that's now broadening. We still do require ABO blood group compatibility. We like donors not to have any intrinsic lung disease if we can avoid it. Questions like a little bit of asthma or a little bit of aspiration at the time of whatever caused the donor's brain death are an issue, and they come up and have to be dealt with. But generally, we've recognized that many of those lungs are quite suitable for use. Unfortunately, many of our donors are smokers, and we don't have the luxury of adhering to the 20-pack-year smoking history restriction. Ideally, people are without much chest trauma. We actually now know that a little bit of dirt in your sputum gram stain is probably not a major issue. So working beyond these and looking at expanded donor criteria is really a very active area of interest, and we'll come back to that in a little bit. As we try to select recipients, we really require principally that they have end-stage lung disease that keeps them from being fully functional despite maximization of medical and other surgical therapies. I think the availability now of bronchoscopically placed valves for severe emphysema may be changing that part of the landscape significantly, as we now have additional therapies short of transplantation to offer them. It has to be a disorder amenable to lung transplantation. You know, advanced malignancies generally are not, with the exception of our little bit of BAC experience. People need to have good functional status, but even this is challenged now by the fact that we can support people successfully to and through transplantation, even if they're so functionally disabled that they really can't do anything. We had an unfortunate young man at Hershey within the last 18 months who developed a severe lung reaction, probably to the bleomycin that he had gotten for a testicular tumor, and he was on ECMO for 2 or 3 months before he was successfully transplanted. Would never have been considered 10 years ago, but thankfully was able to get to transplantation and has had a good outcome to date. Those are the kinds of stories that additional advances need to be made to facilitate. We like people not to have severe systemic disease, you know, horrible heart disease, horrible renal failure, those kinds of things, and I've already mentioned the absence of malignancy. The contraindications are the flip side of all of that. In most cases, recent malignancies are a contraindication. There's unfortunately a large amount of experience with even seemingly cured malignancies from the last 1 to 2 or 5 years returning under the influence of systemic immunosuppression, but those boundaries are being pushed as well. There are some infections, both pulmonary and extrapulmonary, that can be a problem, but you know, hepatitis C and B and HIV are now, you know, potential candidates, and they're not slam dunks, but these are now manageable, if not curable, diseases, and can often exist in a successful transplant candidate. Serious spinal or chest wall deformities make the mechanical things problems. Certainly severe psychological or social difficulties, especially if they threaten an ability to adhere to a regimen, is a problem. One of the most distressing things is somebody who has been smoke-free long enough to qualify for consideration for transplantation, who then relapses at 2 to 3 months post-transplant and begins smoking with his or her allograft lungs. Those are real problems. Obesity is a frontier that's being pushed back a little bit. There is a successful experience transplanting people with BMIs over 30. I don't think anybody's pushed it routinely to 35 or 40, but that's something that's changing. Our CF population is still, unfortunately, plagued with infections with organisms like B. cepacia and Mycobacterium abscessus that are not easy to get around. Burkholderia patients have a high propensity to untreatable sepsis following transplantation. These organisms, even if they are quote unquote in vitro sensitive to antibiotics, are often untreatable, and M. abscessus tends to cause a really nasty post-transplant infection that just burrows through tissue planes and causes all sorts of problems. So most centers now consider those organisms to be contraindications to transplant. The advice about selecting appropriate recipients doesn't necessarily behave in a one-size-fits-all sort of fashion. There are specific times for consideration of transplant, for deciding when to list and so forth, and I won't go through all of these, but we're learning all the time about the utility of new indices to help incorporate functional status into selection criteria. We know that cystic fibrosis is a particularly difficult disorder in which to judge the time of transplant. We know that probably more important than the absolute value of lung function is the number of exacerbations that people are having per year. We know that an exacerbation behaves in terms of mortality prediction models as if the patient has an FEV1 of 10 or 15% less than they actually do. There is something that happens to young women in late adolescence and early adulthood that puts them at particularly high risk for mortal outcomes without transplantation. So all of these are things that are now just trying to be factored into the equation. We know that IPF can behave, in a particularly unpredictable fashion, and most pulmonary fibrosis centers will refer patients with UIP type IPF, the sort of pure IPF, to consideration of transplantation at the time of diagnosis. These are people who, if you take the purest of the pure, are going to have a 50% 2-year mortality that's only been extended slightly by the newly available medications. So most people at least want to get to a transplant center for an initial visit, if not the entire pre-transplant evaluation. So should they get abruptly sicker in the future, they can move ahead. There are other disorders where we have few data to guide us. We had particular concerns about sarcoidosis for a while. It seemed that our sarcoid population was afflicted with a high prevalence of chronic allograft dysfunction, and we actually put a moratorium on the transplantation of sarcoid patients for a while until we could analyze our own data and compare it to national data a little bit more carefully. We were unsuccessful in substantiating that concern, so we were pleased to be able to start transplanting sarcoid patients again. But it remains a problematic disease. The incidence of rejection and post-transplant difficulties in that population is pretty high. As I said, survival in pulmonary arterial hypertension continues to probably outstrip the gains that we're experiencing in transplant survival. So the availability of all these new medications and the numbers of people such as you folks here who take such good care of these patients has made, thankfully, transplantation for them less and less necessary. Unfortunately, because there has been no way to induce tolerance for the engrafted organ, immunosuppression remains necessary, and complications of immunosuppression are unfortunately an all too common problem, as I'll show you momentarily. Almost all centers use a time of surgery and first few day regimen that includes high doses of corticosteroids. Most centers are now using tacrolimus and some sort of what I'll call induction therapy. anti-lymphocyte agents, especially those that are directed against some of the components of the interleukin-2 receptor on activating T cells. Mycophenolate, a cell cycle agent, is part of that, and people end up on a long-term combination, almost always, of tacrolimus, either mycophenolate or azathioprine, and low doses of prednisone. Certain centers are playing with components of this, but I think it remains fairly standard across the world. People often need adjunctive forms of immunosuppression, either to treat episodes of rejection or for other issues. Boluses of steroids, techniques like extracorporeal photopheresis, various lympholytic agents, antithymocyte globulins and so forth are added to the mix as necessary. I wish it were a complication-free procedure, but it's not, and we tend to divide complications based upon the length of time that's elapsed from transplantation. The biggest and most concerning thing that happens at the time of surgery is a disorder called primary graft dysfunction. We don't understand the pathology of it very well. It's not clearly immunological, but there are components of it that seem to be induced by anti-HLA antibodies in recipients and so forth. Hemorrhage is certainly a problem. We unfortunately were party to a very difficult situation that arose in the Southeast a number of years ago. A young man stumbled into an ED somewhere in the Texarkana area and had an ill-defined, undiagnosed CNS problem that ultimately made him brain dead and allowed him to become a donor at the agreement of his family. He had tissues and organs harvested and scattered around the Southeast. Unfortunately, several weeks later, the recipients of those organs and tissues began to return to hospital with what was ultimately diagnosed to be rabies. And it turned out that he was afflicted with rabies, although there was no good way to make the diagnosis at the time he was considered for donation. We got the lungs from that individual donor. They came to UAB, and unfortunately our intended recipient, a young cystic fibrosis patient, had such horrible pleural adhesions and pleural space bleeding that he died of operative hemorrhage and never got the lungs. But it was a very chilling experience for anyone who was involved, as you can imagine. There are various forms of rejection where immunological mechanisms can clearly be invoked, and it's appropriate to call this rejection. We don't see much hyperacute rejection. It develops when recipients have preformed antibodies against the donor, usually against HLA antigens on the donor organ. That's pretty well screened out now of the process, but that's a severe illness that resembles ARDS. Acute rejection is a fairly mild process in the time that it's actually happening. It can actually be asymptomatic, and for that reason, many programs will do surveillance transbronchial biopsies at various intervals early in the post-operative phase. It is, however, a precursor and a risk factor for chronic allograft dysfunction, and therefore needs to be detected and treated. Chronic allograft dysfunction, which is principally obliterative bronchiolitis, but our definitions are expanding and changing, is a different deal. It's principally physiologically diagnosed dysfunction, and it's this actually should have said obliterative bronchiolitis, and it's referred to when diagnosed clinically as the bronchiolitis obliterans syndrome, or BOS, and we'll come back to that. Infections remain an issue, even though we've made significant advances in prophylaxing against them and treating them when they developed. But everybody, if they have any reason to be at risk, is on a variety of different prophylactic regimens for bacterial, viral, and fungal pathogens like PCP and Aspergillus. Some organizations, some programs continue these for long periods of time. Some of them are using just very short regimens. Unfortunately, neoplasms can be a problem. Many of our recipients have been smokers, so they're at risk for not only bronchogenic, but head and neck neoplasms and so forth. There's a particularly difficult problem called post-transplant lymphoproliferative disorder. That's an EBV, Epstein-Barr virus-associated neoplasm, occurs principally in younger recipients who haven't had the immunologic experience with EBV necessarily. And then renal dysfunction, largely because of calcineurin inhibitor toxicity, is a major down-the-road problem, and a variety of other medical toxicities and hematologic issues. Just in graphical form, the complications, the pulmonary complications of transplantation sort of play out over time. Bronchiolitis obliterans syndrome and chronic lung allograft dysfunction, or CLAD, C-L-A-D, is a late problem, as implied by the name. Bronchial strictures, usually related to the procedure itself, happen in the first year. Acute rejection becomes less and less likely with time, but risks like pulmonary embolism, pleural effusion, pneumonia, all of those things tend to go on for the life of the transplant. Primary graft dysfunction, again, as implied by its name, is a perioperative problem, not something that we see later in life. And then these are a host of non-pulmonary complications, and let me just call your attention to renal dysfunction, which can be a perioperative problem, and then again a long-term problem, sometimes requiring secondary renal transplantation, and I'll share a story about that with you in a moment. I'd like to move from that sort of summary of where the field is and has been for the last 10 years to spend the last little bit of time talking about some of these new and I think very exciting developments, some of which are I think very promising, some of which are unfortunately not going to be solved anytime soon. I mentioned that there have been, ever since the inception of lung transplantation, older patients that we would like to be able to help, but the field has been a little skittish about that. When you have a shortage of organs to be used for transplant, and you've got a waiting list full of 20-year-old cystic fibrosis patients, and you mix in the 75, 80-year-old COPD patient, you know, what is the solution to that particular doctor's dilemma? I'm not sure there is a perfectly satisfactory one, but some programs are pushing the age so that if we look over the last decade, you can see the numbers of people in their 60s in blue here who are being done. There aren't any, scales on this, and the numbers aren't really important. But there has been a definite rise in the likelihood that people in that age range can be transplanted. And there are even programs doing people in their 70s, and recognizing that 70 is at least the new 69. I'm holding on to that with lots of hope as it approaches ever closer. We can hopefully continue to push the age range back so that we can help people even at ages that might not have been amenable to that in the past. There is a decrement in survival if you look at age at transplantation and how those patients do. And these curves are in the green and blue, adolescents and young adults, all the way up to people over 65 in black. But you can see, if you look at the sort of median survival here at the 50% point, there's only a year or two difference. It's not like people do remarkably well in one group and horribly in the other. So these factors tend to be overwhelmed by individual recipient-specific factors, and I think most programs now use age as only a relative concern, and most programs are willing to be pushing things out a little bit. One of the other ways to expand the pool of recipients is to try to do things for people who are, according to traditional concepts, too weak or too sick or too unable to rehab, such that they can get successfully to transplantation, and various forms of extracorporeal support are looming large on that horizon. I mentioned the young man with the germ cell neoplasm who got to transplantation after his bleomycin lung injury. There is now an extensive experience of taking people with advanced lung diseases who can barely get out of bed and walk, and putting them on technologies like venous-venous ECMO, so that you can put a very tiny oxygenator in circuit through venous cannulas that can remain in place for a while, and people with that technology in place can get up and around and rehab and walk. Sometimes they need to be ventilated as well, sometimes they don't, and various combinations of things like that have enabled lots of people, especially young folks with diseases like cystic fibrosis, to get to transplantation. Exactly which patients are most suitable for those techniques and which ones may be unsuitable are things that are still being looked at. But you can imagine some of the severe H1N1 flu that you've seen here. I think it was 2 winters ago, we had that horrible H1N1 epidemic that was, just really hitting 30-year-olds and 35-year-olds. And what would you do if you had somebody who recovered from that but still required long-term ventilation and clearly was not going to get any better? That's a situation where ECMO support for some period of time leading to rehab, leading to transplantation might be possible. I've already mentioned the use in situations where people are physically disabled by chronic respiratory disease. And exactly how we fold these into the management of people prior to and then at the time of transplantation is an evolving science, but I think it offers hope to lots of people who might not have been able to avail themselves of these technologies so long ago. It does turn out that, not surprisingly, there's an experience, a threshold below which individual centers probably shouldn't be doing this. This is an interesting study published excuse me, earlier this year, where centers were ranked as either high, medium, or low in terms of their numbers of ECMO transplants per year. The high ones were greater than 15. I think low was 5 or less, and medium was in the middle. And you can see that if you're a lower center, you don't have such good survival. Again, here we're looking at months, so a 6-month survival of only about 60% in some of the less experienced centers, contrasting with that seen in the more active centers. So like most things, I think we need to be careful how we deploy these technologies when we decide to implement them. As I've alluded to, one of the major unsolved problems, probably the most serious unsolved problem, is the chronic dysfunction of the lung allograft that occurs in as many as half or more of patients. It's the single biggest survival limiting process. We used to call it chronic rejection or BOS, bronchiolitis obliterans syndrome. All of that has now been subsumed into a new term called CLAD, or chronic lung allograft dysfunction, in recognition of the fact that it's not all BOS, it's not all immunological probably, and that there are lots of factors that we're really just beginning to understand that contribute to these problems and need to be dealt with. The exact role that immunology plays is unclear. We've always considered transplant rejection principally a cellular immune process, but there's now fairly compelling data that humoral reactivity and anti-transplant antibodies play a role, especially against certain forms of collagen. We recognize that anything that causes chronic or recurrent inflammation in the lung allograft is likely to injure it in a way that's very difficult to recover from, whether that happens from infection and colonization with organisms, whether it happens from recurrent acute rejection, whether it just happens in the, as I continue to take apart the pointer here, whether it just happens in the day-to-day exposure of the lung to the outside air. It is the only commonly transplanted organ that has to deal with that, chronic exposure to the environment. We recognize that airway injury is a problem, and the GE reflux probably factors into a lot of this in very important ways. The sort of classification of CLAD is summarized in this a little bit complicated Venn diagram. In the circle here at the top is the traditional bronchiolitis obliterans syndrome, which is histologically at least identifiable as an obliterative bronchiolitis with a lymphocytic infiltrate and fibrosis around the allograft airways. But we don't demonstrate that very commonly because it's hard to do that on transbronchial biopsies. We rarely have surgical lung biopsies. A fraction of that has been labeled azithromycin responsive airway disease. We know that, as is true in a variety of bronchiolytic disorders, azithromycin has immunomodulatory properties that seem to be beneficial. And most centers now, if somebody appears to be showing early signs of bronchiolar dysfunction, will try azithromycin, sometimes with success. There is a restrictive, a non-obstructive syndrome called restrictive allograft syndrome or restrictive airway syndrome that is not clearly explainable on the basis of bronchiolar disease. When biopsies are taken, they're normal, but the lung changes its compliance properties. And then there's a whole host of other things that, some of which are allograft related, like persistent or recurrent acute rejection, some of which are non-allograft related, like pleural disease, diaphragmatic dysfunction. So we're really sort of still struggling to understand the details and the pathogenesis of all of this, and how A, it can be prevented, or B, treated if it's not preventable. We know that infection is very important, certainly respiratory viruses, community acquired ones. We all bathe ourselves in things from our kids and grandkids, and those are probably benign for most of us, but maybe not so in the allograft recipient. CMV has long been recognized to be a problem and predispose people to chronic problems. The colonization and/or infection with standard bacterial pathogens like staph and Pseudomonas seems to be a problem. We know that colonization of airways by Aspergillus species is a particular problem, especially when it happens near the surgical anastomosis and is a major factor in anastomotic breakdown, especially in the first 6 to 18 months after surgery. There's been a lot of enthusiasm for the potential role of gastroesophageal reflux disease. It's been known for some time that people with just gross aspiration and GE reflux are prone to BOS in a very significant percentage of cases, but perhaps even microaspiration of acid and other gastric contents is more important than we used to think. Almost everybody is on a PPI after transplantation. Interesting to speculate what that's doing to their renal function, as we all now recognize that chronic PPI therapy may be a risk factor for chronic kidney disease. But it's at least likely that acid itself is not such a culprit, because the acid pretty well disappears under the influence of the PPI therapy, but other gastric contents, things like pepsin and bile acids and so forth, may be major players. We don't know whether this happens because of direct airway injury or induction of immune responses. I'll show you some data here in a second to suggest that there may be components of both. But it is among the many things that have been identified as potential risk factors for BOS along the way. This is an interesting study that shows that people do better or worse in terms of chronic allograft dysfunction, here measured as BOS, whether they do or don't have bile acids detectable in the lung on bronchoalveolar lavage. So people who have bile acids do substantially worse in this Kaplan-Meier analysis in terms of developing BOS than do people without. Whether it's because they have bile acids there, or that's just a marker for reflux or a marker for something else, is not well understood. This is an interesting study from the Wisconsin group showing that the development of antibodies against collagen type 5, which may play a significant injurious role in lung allografts, are much more common in people who have reflux, as shown in the dark bars, compared to those people who don't have reflux in the lighter bars. It doesn't occur for collagen type 2 antibodies, and this is a positive control where Epstein-Barr virus extracts are used in the animal model that's used to test for the antibodies, and it doesn't seem to make any difference there. But at least in some aspects of immunoreactivity against cellular and molecular components in the allograft, reflux appears to be a predisposing problem. Because we don't have enough donors, and because it's unlikely that even a massive increase in the number of people willing to donate aren't going to solve our shortage problems, there's a lot of interest in expanding the donor pool. You know, we probably will make some progress if we move to a situation where people have to opt out of donor status rather than opt in like we do now. But even so, the number of usable donated lungs will likely remain low. Only about 20% of donated lungs or potentially usable lungs are useful. And so if you use as the denominator people whose kidneys and liver are used successfully for donation, only about 20% of those individuals will have usable lungs for a variety of different reasons. So there's a lot of interest in expanding the donor criteria, including different definitions of death, such as cardiac death, or this technique called ex vivo lung perfusion, or EVLP. EVLP is a very exciting thing that's now being done in a number of centers. And what it does is allow broader utilization of marginal lungs, perhaps like those that come from cardiac death donors. And it may be a situation where we can use molecular and cellular targets in the donated lung as things that can be modified to improve allograft function. It may just be a matter of giving the lungs an opportunity to get out of this cytokine storm-rich environment that surrounds brain death and take a deep breath, as you will, no pun intended, I guess, and become a little bit more suitable for donation. Whether or not it affects the incidence of things like primary graft dysfunction, does it keep people on the vent longer, does it affect overall survival, are all open questions. Very simply, this is just a preparation where the lungs are hung in a humidified chamber, they're ventilated, they're perfused with a variety of mostly non-blood solutions, but some people use human blood. that's been oxygenated and decarboxified and so forth, and they can be maintained this way for hours to days and then successfully transplanted. The sort of seminal study was published by the Toronto group back in 2011, just very briefly, what they did was to take about 300 consecutive donors, some of which were rejected for obvious reasons, but they then took those lungs that were suitable right off the bat and used them for transplantation. The rest of them, 23 donors, had lungs that weren't deemed suitable, at least not initially, and they were then subjected to EVLP. 20 donors were accepted and ultimately used for a variety of reasons. Mostly the lungs didn't seem to be straightening up and flying right, were discarded. But they ended up with 20 patients who had a variety of different donor circumstances. 11 of the 20 got lungs from brain-dead donors. Some got donated after cardiac death. And then they looked at how those people did. And this may be hard to read, I apologize, but the bottom line is that they did at least as well as the people who got lungs harvested and used in the traditional fashion. These are percentages of various outcomes, primary graft dysfunction, principally at various time points in the EVP lungs as compared to the donor lungs. And you can see that, say, PGD grade 2 or 3 at 24 hours afflicted about a third of the donors who got control lungs, but only 10 to 20% of the people who got EVLP lungs. The time in the ICU, the time in the hospital, airway complications and mortality were all very comparable. So this is something that I think, at least on paper and in a number of papers, has been shown to be very effective and may become a much more standard part of our lexicon. It's been done in kidneys for years. People have taken kidneys and hung them in a perfusion box for a couple of days, and you rarely if ever see a kidney transplant being done at 2 in the morning. Apologies to any of you who are renal transplant surgeons. I know you have to do other things at 2 in the morning, but it's not necessarily been the sort of excuse me, hurry up and rush kind of procedure. The holy grail, if you will, of these sorts of things is trying to figure out a way for the lung to be accepted by the receiving organism as self, as opposed to non-self. And the search for ways to create immune tolerance is something that a lot of labs are looking at. It's been easier to do in livers and kidneys. It's been very difficult to do in hearts and lungs, but there are lots of cellular and soluble factor strategies, ways to try to establish chimerism, so we possess a little bit of the donor's bone marrow and immunological system that helps sort of cushion the entry of the allograft to be able to do that. So there are lots of very exciting things on the horizon, and I think that if we were to revisit this issue in 10 years, we would see a very different landscape from what we see now. Let me close with a very short story featuring somebody that many of you perhaps know. Susan Burrows is a young woman from Atlanta. She came to see us in Birmingham for potential transplantation back in about 2000. And her goal at that time, as she was suffering from advanced CF, was to see Leah, who at the time was about 4 years old, walk to kindergarten the first day. That was the only thing she wanted to do. There's a very touching CNN video about all of this if you want to pull it up on YouTube. That was what we were trying to help her accomplish. She, as a patient, was really one of the most amazing people to be able to work with. She had support from her family, as do all successful recipients. She'd been cared for in CF centers and benefited from research that our people had done and other folks had done. She got great care from our adult CF team and ultimately our transplant team, and thankfully had a very successful experience. She has given me permission to tell her story. I've shared it with lots of people, and she has thankfully continued to do well. She is now out, almost 20 years. She had to receive a kidney transplant because of calcineurin-induced renal dysfunction, probably aggravated by all the aminoglycosides she'd gotten as a younger patient with cystic fibrosis. She got not only to see Leah get to kindergarten, but to get through graduate school as a marine biologist. And she and Keith are constantly posting on Facebook stories from their travels around the world and the lives that they continue to lead. You could question her choice of romantic partners in this particular picture, but she remains a woman on a mission. She runs a foundation that helps cystic fibrosis patients, and she's a real advocate for the sorts of care that she was able to avail herself of. It's been a real pleasure for me to know her, for people who helped care for her to be able to do so. And I think it's a useful way of keeping ourselves focused on why it is that we do the things that we do, and why all of us, including you folks, do the things that you do. Thank you so much for the opportunity to share not only her story, but this hour with you. I'm really privileged to be here. It's great to see old friends and make new ones, and you've got a very impressive operation here. I've got time for questions, I think, if you have any. Thank you again.
Are you familiar with development of developing lungs using printers, three-dimensional printers and cell colony?
I'm not intimately familiar with that, but I've read some of those reports. What has been done most commonly is the construction of a biological skeleton that then has printed on it with lung stem cells of one sort or another, various ways to do that. I'm not familiar with truly artificial lungs being done in any sort of successful way, but
have they been able to take those skeletalized lungs and then implant them in animals effectively?
They have. Human trials with tracheal implants and things like that have already happened. Tracheae that are constructed out of a biological skeleton and then colonized with tracheal cells have been used in clinical trials. I'm not aware of any trials with actual whole lungs yet, but it's only a matter of time. The new technologies that permit that are really astounding. Another question here? Yes, sir.
Yeah, kind of relating to the last story you had, is there any common factors that describe long-term survivors?
There probably are, but we don't know what they are. That's a very good question. What is it that distinguishes the person who does extremely well, hardly ever has rejection, doesn't develop any chronic problems, and the people who die at 2 years because of a profusion of those problems? I can tell you lots of factors that seem to be important, as we've just discussed, but nobody's really been able to hone it down to one or just a couple that we could either select for or try to modify. I had a high school science teacher who said that if you want to win a Nobel Prize, it's simple. You just take a group of people who seem to be all the same and discover what makes half of them different from the others. Like, why can some of us drink and not become alcoholics and some of us become alcoholics? Why do some people, seemingly indistinguishable from another at the outset, get good outcomes after transplantation? So once you figure it out, you can buy your ticket to Stockholm and you'll be good to go. I wish I had an answer to that very good question. The question was, what is it that distinguishes people from one to the next? Yes?
Has anyone done surgery same time for GERD, like having a wrap before they get, while they're getting their lung transplant?
Yeah. The question is because of the potential importance of GERD, is there any enthusiasm for doing a Nissen fundoplication or something like that at the time that the lung is put in? It has been done, not on a large scale. You can imagine that people who are sick enough to require a transplant are probably not the best operative candidates for multiple procedures like that. What most places do, because there's presumably a time factor that's important, the length of time that the allograft is exposed to reflux, they will aggressively evaluate people pre-lung transplant for the possibility that GERD is an issue, and then as soon as they're healthy enough, within the first few weeks after transplant, they'll go ahead and do the fundoplication. And that seems to be effective, but there aren't really any long-term data yet. But what you're proposing is a useful goal. Good question. Other questions or comments? Well, if not, again, thank you very much for your attention, and thank you for the opportunity to be here.